Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening, everyone, and welcome to another powerful, that's what I call it anyway, episode of Pause for the Truth. I am your co-host, Jocelyn Turner. Tonight, we're creating a space for a conversation that is long overdue, one that impacts millions of women, yet it is often misunderstood or minimized. I am talking about, it's not minimized, not talked about enough. I'm sorry. Our topic is menopause beyond the hot flashes, where every woman should know. Now, I cannot do this podcast alone. And even though we just got a look from Dr. Kane when I mentioned menopause. But Dr. Kane, we put men in it.
Yeah,
So,
yeah.
what I'm
I,
saying, before I introduce our guests, welcome. How are you doing this evening?
I'm doing fine. Even though you put men in it, we already in it. You walk through the door and you're trying to figure out who you're coming home to. So
Wait
it
a
can
minute.
go
Well,
either
listen.
way.
Well, by the time we finish tonight, Dr. King, hopefully you'll understand that better. Our audience will understand that better.
There you
Coming
go.
from behind the scenes, oh my goodness, Dr. King, he changed his name to behind the scenes guy. I just noticed it. Is our technology guru, Tyrone Jackson. How are you doing this evening, Tyrone?
I'm doing well, and you did say you have men in it, but the bottom part of it said men pause. So it's got every place to pause.
Well, welcome
Not
to you. And
PAWS either.
listen, I can't with these guys. We are so fortunate tonight to have Dr. Lorraine Brown. Listen, Dr. Kane, she has so many initials and credentials behind her name. I couldn't figure out what to say, so I'm just gonna say, welcome, Dr. Brown. How are you doing this evening?
I'm doing well. Excited to be here. Thank you.
Wonderful, wonderful, wonderful. Well, to our
You can
audience, thank you for joining us.
you can call her alphabet soup.
And Dr. Brown is not new. We've had her on before, and we had such a good time. Any of our guests, I need to warn them that if you're really good, we're going to call you back. So just know that. So Dr. Brown is has such a wealth of knowledge that we really, and her reputation here in Northeast Florida speaks for itself. So we are super excited. I reached out to Dr. Brown. I said, Dr. Brown, I just had a conversation with some ladies at okay, I won't say where because I want to put them on blast just in case people know about me.
Hmm.
And they just when I told them what we were talking about, they were just like, "Oh my God, ask her this, ask her that, ask her this, ask her that." But we're talking about menopause beyond the hot flashes. Flashes, what every woman should know. For many, menopause has been reduced to a few symptoms and a lot of silence. But the truth is so much more. It affects a woman's physical health, her emotional well being, her relationships, and her overall quality of life. And for many women, especially in our communities, this journey can feel confusing, isolating, and even dismissed in healthcare settings. Tonight, we're changing that. We're bringing truth, clarity, and empowerment to this conversation so that women are not just informed, but prepared, supported, and confident in advocating for their health. We are honored to be joined by an incredible expert, as I said, in Dr. Lorraine Brown, who will help us unpack what's really happening in the body, what symptoms we should not ignore, and how women can take charge of their health during this important stage of life. So, whether you're approaching menopause, going through it, supporting someone who is, or you're a clinician wanting to better serve your patients, this conversation is for you. Let's lean in, learn together, and most importantly, let's pause for the truth. I love how I'm writing the name of the organization, Dr. Kane, into my opening remarks. Let's just go ahead and pause for the truth. So, Dr. Brown, let's delve into this because, again, I got all kinds of of just people just shot all kinds of questions out at me. But I'm going to start by asking, for those who may not fully understand, what exactly is menopause and what's happening in the body during this transition?
Perfect. Perfect segue into the start of our conversation. Can we can we place the PowerPoint up? Perfect. You can advance to the next slide. Y'all already know who I am. You can advance to the next slide. So I really, so what is menopause? And I'm glad, Miss Jocelyn, you brought that up as kind of the first like level setting thing that we need to discuss because in our community, sometimes we just don't talk about exactly what is going on. But basically, if you break down the root words, the Latin roots of meno and pause, pause means stop and meno means menstruation. So the cessation of you having your regular vaginal bleeding is the definition of menopause. But the root cause of what happens is that your ovaries, those little organs that produce all the hormones from the time you were born up until through menopause, they essentially stop functioning. So our gentlemen on the call were chuckling about coming into the house and it being a different woman or just the things that are they're experiencing, but essentially this organ in our females bodies is failing. So from the time you're born you have a bunch of eggs, and as you age that egg count dwindles. So menopause represents the total loss of the hormone production from those ovaries. So the main hormones that our ovaries produce are estrogen and progesterone, those female hormones, and a little bit of testosterone too. So if you can imagine an organ failing your body and not producing some of those essential hormones that you need, not just for your reproductive system, but there are those hormone receptors, every organ in your body, which is why menopause can affect so many different things. You don't have those hormones anymore, you can have a variable experience with regards to how you experience menopause. So essentially, 1 year with no period, that signifies that you are in menopause. Or if your ovaries stop functioning or if they're removed, that is the definition of what menopause is. So when that happens, you are postmenopausal for the rest of your life. Before that happens, you are premenopausal. And there's a lead up to that where you can be perimenopausal. Let's go to the next slide, and please y'all jump in if there's some clarity that needs to happen.
Well, Dr. Brown, I'm glad you broke menopause down because it doesn't mean men pause, as one of our guests, our gentlemen have said before. So thank you
Right.
for now schooling them so they'll know. Okay, thank you. I'm sorry. I just had to slide that in.
Yeah, we had to reiterate that. Yeah. So the thing is that, menopause, like I said, when the ovaries stop functioning, but leading up to that, every day the ovaries are aging and decreasing in their function. So that's why even the lead up to that menopause day can be tricky. And for some people, it can start very early, even as young as in the 30s, 35, early 40s, that lead up to that day. So you can get a myriad of symptoms as your ovaries are failing until menopause. And then, like I said, postmenopause is another transition point too. So it's all the rave now. And I talked about this with our behind the scene guy earlier, for it to be just kind of commonplace now on TikTok, social media, in different places, church or other places we go, for people to raise their hand and maybe volunteer these symptoms. But for so long, it was taboo to even talk about it. And the thing is that our ancestors, they did make it through. You can make it through. Like, it likely won't kill you, but some of these symptoms for some people can be so debilitating that it impacts their life in such a great way. Imagine leading a busy, complicated life and suffering from some of the symptoms that we'll discuss later. When we have the knowledge now to maybe treat those things or better manage them or just understand them, I think it makes for a better conversation between the doctor and the patient.
Yeah, I was going to ask, is there anything a woman can do to prepare for menopause?
Yeah.
Uh,
Yep.
yeah.
Good question. So I think one of the most basic things is just knowledge, being prepared. Much like when a young girl goes through puberty, it can be terrifying if you weren't told of what these body changes are that are occurring. So the normalization and the education around physiologic menopause, like these are the next changes that are going to happen. Don't be alarmed, but let me know. That I think that's a key, a very good key to success. And then the basis of all good health is having a solid foundation. So there are certain things, certain conditions, certain things that we can expose ourselves to that can exacerbate the symptoms of menopause. So you might want to avoid those. And we'll get descriptive about those in a second. Next slide, please. So, like I said, there's receptors for these hormones on every single tissue and organ in our body. So when someone comes to me and it's like, my hair is falling out and I'm really irritable and I'm 49 years old and my periods are irregular, yes, it could be a coincidence that you have three different medical problems, but it's more likely that this could be related to your ovaries changing that hormonal production over time. And it can be very distressing. Some of these symptoms, sleep disturbances, whether it's difficulty falling asleep or waking up from sleep because you're having hot flashes and night sweats or drenched in sweat, the weight gain, and it can be unexplained. And it's especially in that midsection because that's where those hormones can really have an effect on your abdominal fat. So I mentioned dry skin, breast changes, difficulties with intercourse, mental fog. All of these things have been attributed to menopause. Now, it's important though, if you do have any of these symptoms, to discuss them to make sure we're not just blaming everything on menopause and rule out, more dangerous things that could be occurring. But it can be normal, it can be physiologic for you to notice changes in all of these symptoms as you make this menopausal transition. Even joint pain, and I see patients sometimes they've been to three or four different specialists because they have a myriad of symptoms they can't explain. They're all on antidepressants because they feel sad and irritable. They are
Mm.
having new onset joint pain. They're losing their hair. And then I ask them about their reproductive health, and it makes sense that, you know what, the decreases in your hormones may cause the GYN problems, but also these other symptoms can be associated.
I remember when I went through menopause and I started having hot flashes. I was just like, oh my God, what's that? I mean, I would just be standing up talking to someone, and all of a sudden I just sweat just pouring. And once I realized that's what it was, then I would tell, and people would ask me, "Are you okay? Are you okay?" Because they just see me. I said, just give me a few minutes, and I did, and it went away. And fortunately, it didn't last long from me, maybe 3 or 4 months. But I know some
Mhm.
folks who've really gone through it, and the only symptom that some people have told me they had were the hot flashes. But
Mhm.
listening to some of these other folks, they talk about the perimenopause phase and how
Yep.
they're different feelings that they're having or effects of menopause.
Yeah, and it's so prevalent. That's why there's a huge spectrum of how we all experience it. And we do know that African American women sometimes experience more severe and more a prolonged
Hmm.
time of hot flashes as well. Every day there's 6,000 women entering the menopausal transition. So it is
Hmm.
rampant. But like I said, it's a spectrum. Some people don't have any symptoms, but some people are really debilitated and have to change their activities. Can you imagine, especially the men on the call, if you're conducting a business meeting and all of a sudden, without warning, you feel hot, start sweating? It's so embarrassing. And I feel like that is the secondary effect
Hmm.
of these menopausal symptoms. Like you are trying to be a normal person and conduct your life, but this unpredictability around how you feel and you can't control it. And you can do things to kind of minimize those symptoms. You can breathe, you can avoid caffeine, alcohol, spicy foods, but it can be variable how each of us experience it. The average length of time after menopause that people experience hot flashes is about 3.5 years. But some people, just like you mentioned, can experience hot flashes 10, 15 years even after menopause.
Why you mentioned African Americans? So why is that?
Yeah, we don't know why. Part of it may be diet, part of it may be genetic predisposition, but it's not fully elicited. And it's interesting because Black women tend to experience more frequent and more severe hot flashes. Asian women tend to experience no hot flashes at all. There was an
Mm.
interesting article that I read recently. Part of it may be cultural conditioning. I don't
Mhm.
Mm.
necessarily believe that because I think that all people are resilient and can kind
Mhm,
of get
mhm,
through, but some
mhm.
people felt like that may also predispose us to how we experience a hot flash. Like if we are having a hot flash and we were told that you got to ignore it, it's just normal, you may express it differently. But I also think that there's just a lot of factors that can influence the way your body interacts with that loss of hormones that makes it variable, even with sisters or twins. Like no one person is going to experience menopause in the same way as other people.
It's
Does
so
body fat
interesting.
have anything to do with that? The amount of
What did
body
you
fat? The amount
But
of body
yes,
fat.
yes, yep, definitely the amount of body fat can have a lot to do with it. And it's kind of sometimes oxymoronic because we think that when the more obese you are, you can have estrogen produced by those fat cells that are still there. So you would think, oh, maybe I got a little bit of protection. But sometimes we see the hot flashes are more severe in our obese patients. And then also for after menopause, when your ovarian function is not producing any more estrogen, it's probably not helpful to have your fat producing estrogen as well. That can predispose you to certain cancers, um, basically endometrial cancer, even breast cancer. And that's the mechanism that hormonal influence can play with being obese.
So, I think about menopause, and one of the things that women start feeling are mental and emotional, how it affects your mental and emotional health, mood swings, anxiety, brain fog. But then I think about when a woman is pregnant, how the symptoms, and it's like, man, you can't get rid of those darn symptoms. They just affect us at so many stages of our life, right?
Yes, definitely. And it shows how much of a fine balance our body is. Things get perturbed even just a little bit. You can have a total body. One of my patients called it a total body failure. Like it's almost like
Mm,
you are not in control of how you feel. You're not in
mm,
control of how you act. It's almost like you're watching yourself in a movie. You did not
wow.
choose to have rage. You did not choose to be irritable, but it's that instability of your hormones kind of makes it that way. And that's why perimenopause is also so distressing to so many people. Typically, they're young and that might not be the first thing they think of
Mhm.
when these body changes start to happen. And as our ovarian function decreases, it doesn't go down in just a solid little slope that's predictable, like every day less and less. No, it is peaks and valleys. And that's why the Latin root word for uterus is hyster. So like hysterectomy,
Yeah.
but it's also hysteria. So in the
Mm,
old days, before we really understood what was going on with women during perimenopause and menopause, they locked those women away. They were
mm,
crazy. They were literally like their husbands were, I can't even control her. I don't even know what's going on. So those
mm.
women were labeled as hysterics and they were locked away due to likely, a perimenopause and menopausal transition.
Wow. Wow.
Yeah, I
I
know.
have more questions for you, but I know you had some more slides, so I probably will
Yeah,
just wait
no,
until you get to a slide.
it's okay. You can jump in because if we talked about it, we'll just pass it. Next
All
slide,
right.
please. Yeah, so this is important. All the time, people are like, I need some blood work, or tell me what's going. How can you tell I'm in menopause? Like, help me out. Let me figure this
Mhm.
out. So, menopause is a clinical diagnosis. So, somebody can tell me I have not had any bleeding for 1 full year, and within the right age range, over 40, you can reasonably say that your ovaries have stopped functioning. Okay. Now, there are other situations. Like, what if somebody had a hysterectomy? Or what if somebody is 30 and they haven't had a cycle for a year? There are blood tests that we can do that can confirm that your ovaries aren't working anymore. So if you are someone just kind of out and about, haven't had a period for a couple of years, it is reasonable to assume that you have crossed that menopausal pathway. Next slide. So this is very important. So like we said, once your ovaries stop functioning, that whole communication between your brain and your reproductive organs, that is stopped. So that means that you can't get pregnant. You don't have any more eggs, no more hormone production. You can't get pregnant. And that also means you should not have any bleeding. it is never normal to have bleeding after menopause. Most likely, it's not cancer, so you don't have to think the worst on that end of the spectrum. But you always need to get evaluated if you have bleeding after menopause to get that checked out, to rule that out, and to also evaluate for other conditions. Like Dr. Kane mentioned, obesity and the fat cells that can produce some hormones. So sometimes, even if you're postmenopausal, there still could be some degree of hormonal production that can predispose you to cancer. So you don't want to miss that. So bleeding can be one of those first signs. You might not have any of the symptoms, but if after menopause you have vaginal bleeding, make sure you get in to be evaluated.
If you've
Well,
had a
Dr.
history,
Dr. Brown, I was going to ask, because I hear it quite a bit. So a lot of women ask, well, how long after I go through menopause should I become suspicious if I start bleeding again? Okay. I know what we learned in medical school, but but
Exactly. Well, I feel that now in the age where we can do tests that are safe and non-invasive very quickly to ensure that there is not anything abnormal, if it has been 12 months and you're not taking any extra hormones, there's no other influence that could have made you at risk to have bleeding, then you should go in and get evaluated. At the minimum, just a quick ultrasound. Because what I need to do is look at your womb and make sure that there's nothing growing inside. Make sure there's no tissue building up because there shouldn't be. So many times you can have, a UTI or a little bit of trauma from intercourse, and that may cause some bleeding. But bleeding like a period and bleeding more than a day or two that's heavy, that is the distinguishing factor. So I got a low threshold because if you do develop endometrial cancer, sometimes there are precursors that we can catch before it develops into cancer. So we always want to stay on top of that. And if you have a trusted provider, they're not going to order too much or do too much or expose you to things that you don't need, but just that surveillance to make sure that we're not missing anything.
Well, and I got a question, and my thought is, okay, so as a woman has made it through menopause, how does she know? Do the symptoms just stop, or what happens after she's made it to the other side?
Good question. Good question. And see, that's the part where you got to rely on what did your mama experience and just got to pray about that because everybody's experience is different. I have some people, just like Miss Jocelyn said, they may have a few months and then they resolve. That average time of experiencing, especially the hot flashes and night sweats, is about 3.5 years. So that's what we quote on average. But if patients are still having symptoms even after that, it's not abnormal. It takes time for each individual's body to normalize that new normal of lower hormonal exposure, essentially. I have some patients in their 60s or 70s still having hot flashes. So it's a variable. Yes, it's a variable response.
one
wow.
of the things I used to see a lot of here, let me put it this way. One of the things I used to hear a lot from some of the women, especially, I don't know, 10, 20 years ago, was Dr. Kane, I went through menopause 12 years ago. All of a sudden, it's back. Okay.
Right.
And
Yeah.
they ask, why is that? And I'm going, I don't know. It could be the diet. I'm not sure how much of estrogen that they have in the foods. If you remember one time, they was
Hmm.
adding all these estrogens to our cows and to our meats and stuff of that nature. And I honestly did not know what role that played. I had suspicions, okay, but
Hmm. Hmm. Hmm.
so I don't know if you've read anything more up to date on it than old man memory. Uh,
Your old man memory serving you well. That's a mixed pot. We generally think if you start having new onset symptoms 10 years after you went through menopause, we need to do further investigation because it could be something else causing whatever symptoms that you're having. That's a little atypical, but I do hear that a lot. And I definitely agree with you. Some of the um foods, supplements, some of the extra things that we are doing can sometimes cause unintended side effects. There are some substances that can increase your body's production of estrogen from those fat cells. So you might not want to try that, or you might not want to disturb your new normal of your hormonal balance, because that can definitely put you in a tizzy. Just like Miss Jocelyn mentioned earlier, pregnancy, in any short interval of hormonal flux might cause a myriad of symptoms because your body has gotten used to that new steady state.
And I was going to
Next
ask,
slide.
what are some common ways menopause symptoms are dismissed in healthcare settings?
Yeah. Well, I think that if patients aren't aware that, sometimes these symptoms could all be interrelated, they may just present to the doctor, even if they're having hot flashes, they just may present to the doctor with hair loss and fatigue. But getting that full, what we call review of systems, to really go down the list and say, what else are you experiencing? That might prevent people from going on wild goose chases. But the common thing, the most common ones that are distressing to women, that they complain to me that maybe other people have kind of brushed aside, or that inability to lose weight or weight gain.
Yeah.
That change in metabolism is really distressing for women. They've been healthy their whole lives, and sometimes they haven't changed their diet or exercise, but now have just barriers to being able to maintain their weight or lose their weight, especially that mid abdominal obesity. The fatigue is a really, really bad one. It's just kind of unexplained, kind of wiped out. The mental fog, that's another one. Patients are just like, I just feel so forgetful all the time, and there's nothing else that can really explain it. So I feel like those are probably the most common ones, because these patients are still very young.
Yeah.
You're not thinking somebody has dementia. So why are
Mhm.
you not having why are you having mental fog? And then it kind of spirals, because you're trying to be high functioning, balancing all these things. You don't want people to judge you. You don't want people to think anything is going on. And then we might not talk about it in the beauty salon. We might not talk about it like at the birthday party. Like, we just might not
Mhm.
talk about how we're
Mhm.
really feeling. And that also makes a lot of patients at risk for mood disorders. They're anxious, they're depressed, because they just don't understand why they don't have control over their bodies anymore.
Well, is
They
there
haven't been around. They haven't been around me because I bring it up everywhere I go. All kind of topics. They're like, oh, here she goes. And what we talking about today, Jocelyn? When I go to the hair salon, I'm just
well,
You
like,
got
hey,
to.
you
is
You
there
know.
got to.
any
So,
information that shows increase into doing menopause or perimenopause, where women become more allergic or have a higher increase in allergies to things?
Well, that and Dr. King might can jump into that. I feel like that's probably a midlife transition anyway. I see that a lot for women in their 30s and 40s, especially after they complete their childbearing. The incidence of autoimmune disease and just allergic type symptoms, we are seeing upticks in that. I don't want to necessarily correlate it to hormonal changes, but we definitely are seeing a lot more associated with that. It may have something to do with chronic stress. I think that's a huge component of it. And then if you add um, perimenopause on top of that, definitely patients can experience a myriad of symptoms. But I think that has more to do with kind of midlife itself.
And a lot of it may be due just to environmental issues that we see going
mhm,
on these
mhm,
days. I mean,
mhm.
Yeah.
we are experiencing global warming, and
Hmm.
I think sometimes our trees are in menopause. They don't know if it's they don't know
Right.
if it's winter, fall.
Right.
You see,
Right.
they shed their
Yeah.
leaves, in the middle
Hmm.
of spring, and then they grow right back. And so
Yep.
a lot of it may be just due to the effects of global
Environment.
warming. And I'm
Hmm.
with you. I don't know a reason. I just make sure what I can investigate that is
Yep.
nothing bad that
Bad.
I can prove.
Exactly.
And then after that, I send them to you.
Yeah. And I was going to add, I mean, this is kind of unrelated, but just the incidences of younger people getting colon cancer, younger
Yeah,
people getting breast cancer. Some of this
Mhm.
exposure to the things that we're going to see when we're 30, 40, and 50 started a long time ago. And unfortunately, like for the patients that are in their late 20s or 30s getting colon cancer, that exposure probably didn't happen a year or two before they got the diagnosis. It
right.
probably was a long standing exposure, and it's so multifactorial. Is it my cell phone? Is it the radiation? It's a lot. Is it our
Mhm.
food?
Mhm. Mhm.
It's just a lot that goes into it. But I think instead of living in fear, empowering patients about what's normal and what's not normal in order to start that investigation. I think that's one of the main keys to success.
So
Agreed.
we're gonna take a pause right now. We have what we call, Dr. Brown, a mid-show moment, and it gives our guests an opportunity to get a drink of water or something, and then we'll continue the conversation. If you're just joining us, we are fortunate to have one of the leading experts here in Northeast Florida in the in OBGYN and women's health, Dr. Lorraine Brown. We're gonna take our mid-show minute, and then we'll be back with the discussion. Have your questions ready for Dr. Brown. Take it away, Tyrone.
You having brain fog.
So that menopause thing is really true, huh?
Right.
Yeah, I wish that was easy, but a lot of updates have been made with the streaming platform that we have, and the mid-show minute is buffering, so it's going to take up a few minutes. So let's
That's
go ahead.
fine. I have another question I can ask Dr. Brown because I
Okay.
recall, Dr. Brown, people talking about osteoporosis and bone
Yes.
health. Is there any association between menopause and osteoporosis and bone health?
Yep, excellent question. So remember, those estrogen receptors are everywhere on our bone, heart, brain, everything. So with our bone health, it's important to make sure that we can accurately diagnose when you go through menopause. If you go through menopause too early, or like your late 30s, early 40s, and your body doesn't get as much of that estrogen exposure, that could significantly put you at higher risk for osteoporosis and bone loss. And for patients, even if they go through menopause at the average age, 51 in America, if they go through menopause at that age, if they're at high risk for bone loss, like if you had a mom or a sister that broke a hip early, or is very frail, or you're very petite, or you don't do a lot of strength training or exercise, that's gonna, and if you're on medications that make your bones weaker or your immune system weaker, you could be at higher risk for fracture. And then in that instance, we may need to have a discussion about giving you some hormonal therapy to make sure we optimize your bone health. For the average person, if you go through menopause at the appropriate time, you're at average risk of bone loss. You don't necessarily need to replace the estrogen that your body is no longer making. But if you're at high risk, or if you went through menopause early, we definitely need to give you some consideration, because it was intended that you would see that hormonal production until your natural age of menopause. So if something perturbs that, we definitely need to have that conversation.
Is there and I don't know if you're talking about it. I want you to go on to the next slide, but you just prompted made me think of something else. When you talked about the
Yeah.
natural stage of menopause, did you mention, is there a normal age, if you will, that
Yeah. Good.
we should go through menopause?
Good question. You can advance to the next slide. So the average age is 51. So that still means that half of us will go through menopause after 51. But average age in America is 51. And that's important because in different countries, it's different ages, probably due to environmental factors, diet. I mean, our BMIs here in America, it's a lot that goes into our average age. So if you go through menopause at less than 40 years old, that's premature menopause, and you're at significantly higher risk of heart disease and bone loss. So that typically it can happen naturally, or it can happen if you had chemotherapy. Sometimes certain people, there's certain genetic mutations. You can be predisposed to go through menopause very early in your 30s. But if you have a hysterectomy or get both of your ovaries removed at less than 40, you need to ensure that you are getting at least another 10 years to kind of catch up with that hormonal production that you would have had if you went through a natural menopause.
Yeah, there are just so many things because you brought up heart disease because that was going to be a question I was going to ask in terms of how does menopause impact a woman's risk for heart disease and other chronic conditions? And you may have
Right.
that coming up on a slide, so you can just say, "Hold on, Jocelyn, let me
Yeah,
talk
no,
about
no.
treatment first."
No, it's okay. But yeah, so definitely cardiovascular disease in general can be accelerated if you take away those hormones too early. It was like God designed a fine balance of how the clock should tick. So
Mhm.
we suspect, again, patients that are at average risk. If you go through menopause at 50 years old and you don't have extreme cardiovascular risk factors that would, you know, number one, be contraindicated in hormone
Mhm.
replacement therapy, then you probably got enough exposure to be heart protective. But if you lose your ovaries at 20, you're going to greatly increase your risk of cardiovascular disease because of those
Mm.
same receptors that are on your heart to give your heart the estrogen exposure that it needs, the same receptors that are on your bones to make them strong. It all works in a fine balance. And our GYN hormones, estrogen, progesterone, testosterone, are all a part of the hormonal system, the endocrine system. So that can impact your insulin and how you process sugars. It impacts your cortisol, how you react to stress. It impacts your thyroid and how the thyroid kind of controls your metabolism as well. So everything is interconnected. And sometimes, there can be indications. There's cancer, there's, certain cysts where you have to remove those organs, but you have to make sure that you're also considering those long-term effects, not just that affect the GYN system, but your bone and heart health are the top two.
All right,
Wow,
Ms.
if you're
Johnson.
just tuning, I was
Go
just about
ahead.
to say, if you're just tuning in and you have questions for an expert in the area of menopause and just women's health, make sure you ask a question. Get that question ready now because we're going to take a break and have our mid-show minute, and we'll be right back with Dr. Lorraine Brown.
Welcome to Pause for the Truth Mid-Show Minute. Today is Tuesday, April 7th, 2026. Today we go where few tread, menopause. It's a topic that has been shrouded in whispers and misconceptions for far too long. For too long, women in our communities, especially African American sisters and those in disenfranchised groups, have been told to suffer in silence, to just get through it. This narrative has left too many of us feeling isolated and unprepared. That silence is dangerous, especially when research shows Black women often reach menopause earlier and endure symptoms like hot flashes for nearly a decade, longer and more intensely than our white counterparts. To bridge this gap, we are answering the top 10 questions every woman needs to know in plain English, so you can feel informed and empowered. First, what is it? Menopause is simply the point where you haven't had a period for 12 consecutive months because your ovaries have retired. But the journey there, called perimenopause, can start years earlier, bringing its own set of changes. If you feel sudden anger or sadness, know that it is a physical drop in hormones affecting your brain chemistry, not a character flaw. These mood swings are real, and you are not alone in experiencing them. While hot flashes are famous, keep an eye out for joint pain and brain fog that makes you forgetful. These are real physical shifts happening in your body. You might also notice your skin becoming incredibly dry or sex becoming painful due to thinning tissues, both of which are treatable. Don't hesitate to seek solutions for these intimate concerns. If you are gaining weight specifically in your midsection, that is your metabolism shifting how it stores fat. This change also impacts your heart health and bone density, making proactive care essential. Sleep issues are also common, driven by a triple threat of night sweats, anxiety, and dropping melatonin. A consistent sleep routine can become your best friend. When it comes to hormone replacement therapy, it can be a lifesaver for severe symptoms, but because minority women face higher risks of heart disease, you must demand a tailored conversation with your doctor about your personal risks and benefits. Finally, if you feel dismissed by your provider, remember that your symptoms are valid. Bring a log of your experiences, and don't let the strong woman trope keep you from the care you deserve. You have the right to be heard and treated with respect. Menopause isn't the end. It's not a disease, and it doesn't mean your life is over. It's a transition to your power years, a new chapter of wisdom and self-awareness. So let's take up space, share our stories, and advocate for our health.
Wow, Tyrone does an amazing job with his
Yeah.
research, speaking on behalf of women. Thank you, Tyrone. Men do pause for the truth.
That was great.
Dr.
Very
Brown, what
great.
are the most effective options for managing symptoms, both medical and natural approaches? Oh, wait a
Perfect.
minute.
Yes.
You got some good stuff here. Forget my question. Go ahead and talk about this.
Yeah, no, it's okay. Perfect, perfect little segue. So basically, I feel that the first step is just really understanding what's happening with your body. I don't want anyone being hysterical about the changes that are natural physiologic changes. So giving them that education about this is what you can expect during this transition is the foundation. But then also encouraging them that it's a spectrum. You don't have to take medication, but it's available if you become debilitated. Um, Let me see my can you put the slides back up there? But there we go. Perfect. So diet, things that can exacerbate those hot flashes, like I mentioned earlier, caffeine, alcohol, and spicy foods, they can definitely make the severity and frequency of those hot flashes a lot worse. Eating soy-based products can actually be helpful. And then there's some
Hmm.
over-the-counter supplements like estrogen or amberin. They're based in soy. So soy can use that. Soy is like the base, and it can kind of convert some of your natural hormones, hormone substrates to estrogen. So that can sometimes be a balance as well. With regards to that bone health, getting plenty of calcium and vitamin D in food, primarily, you should try to eat it first, and then if you can't get enough, use supplements. But really trying to live as clean as possible so you won't have any confounders. So that if you start to feel irritable, if you start to feel more tired, if you start to have hot flashes, try to avoid things that are going to make those symptoms worse.
It's so funny when I go out to eat with ladies. We didn't when we were younger, we didn't have the conversations about what we're going to choose for dinner. Now, well, we need to watch our salt. We got to do a low fat diet. Now we got to avoid
Right.
caffeine, alcohol, spicy food. Oh my God. Our
Yeah.
resident dietitian keeps telling us you need to eat more fresh fruits and vegetables. And oh my goodness, it just seems like that's just the way to go. I'm sorry,
Yeah.
I digress. I just had to insert that, Dr. Brown.
No, I'm sure Dr. King lives that every day. Like people come and they're swollen and they got a headache, and I'm like, "What'd you eat for lunch? Like, what's going on?" Like we literally
Exactly.
are what we eat. Like it can change your mood, it can change how you feel, and I think it's more pronounced the older we get.
Yeah.
Definitely. Next slide. So exercise and relaxation, because like you mentioned, Miss Jocelyn, taking that deep breath, it really helps a lot. So being aware that, you know what, I'm probably gonna have some hot flashes today. Let me figure out how I can manage them myself,
Mhm, mhm.
is instead of being so anxious about having them in general. I feel like that helps patients a lot. And then a lot of my patients do take up meditation or yoga or Pilates, something new in this midlife time to just help better balance the stress that occurs with this transition. Next slide. Other tips, dress lightly and in layers and having those little fans that lots of my friends and patients have. This is very important. We haven't touched on this, but intercourse. This is very important. So I'm gonna just tell you, menopause, again, you got receptors in your vagina that need estrogen. So once the estrogen goes away, there are changes that can happen, physical changes. So not only may you have decreased libido, but you may have painful intercourse, dryness, all those things. The thing is, if you would like to continue to have sex through your postmenopausal years, you need to keep having sex. It's not a myth that your vagina can close up. Like that literally can happen. You can have labial agglutination. You can have a lot of things happen. So
Say
lubricants,
what?
vaginal, yes,
Gee
it
whiz.
literally can it can happen. So it normally takes months to years. That's not one of the immediate postmenopausal symptoms, but once your vagina sees less estrogen, it's a condition called vaginal atrophy. So you can get more UTIs, you can get more trauma with intercourse. The tissues become thin and delicate, and they can agglutinate or close. So you want to make sure you keep that top of mind. And for any of our listeners, if you are in that situation, don't feel like hope is lost. There are things we can do to help you and to reverse that, but you don't want to get there in the first place. So I would encourage you, if you want to continue to have sexual intercourse, that you don't stop, because you just don't want to do that.
So, Dr.
Yep.
Brown, since I am a health educator by profession, people ask me questions, and sometimes I try not to get embarrassed when they ask me because I know I'm a
Yeah.
professional health educator. but I think about when I used to do reproductive sexual health education, and if this topic of menopause and keep having sex and the vagina closing up, the first thing I would think about if someone doesn't have a partner is that when the battery operated boyfriend comes into play. I'm sorry, I'm asking for the people in the back. I'm just asking.
Right. For
I,
everybody, for public
I knew
health.
it
I
was
got it.
coming, but
She couldn't resist. So yes, so definitely that, but even more importantly, just the lubrication and some form of interaction with your vagina. You just don't want to let it get cobwebs and like shut it down because it's going to be
oh, man.
hard to you don't that can be dangerous. So you can go as far as your friends, the battery, you can go as far as that, but keeping some degree of penetration, some degree of lubrication. There are medications that sometimes we can help prevent some of the acceleration of that dryness and atrophy. So yes, you want to stay active.
So
You don't use it,
and
you
I
lose it.
and I brought it
Exactly.
up, Dr. Brown, because I do
Mhm.
want people to normalize these conversations to better
Yes.
support women, right? And be
Yes. Yeah.
honest. If you cannot have the conversation with a girlfriend or someone who is not knowledgeable in the area, make
Right.
sure you're going to a physician on a regular basis. If not for an
Yes.
OBGYN, that you have a primary care physician and have these
Right.
real conversations and just spot me on the
Mhm.
road and ask me. I don't mind asking the questions. I'm not embarrassed, right? Because the
Definitely.
more I know, the more I share. So thank you
Mhm.
for saying that because I didn't know
Yeah.
this about the vagina closing up. Oh my goodness.
Yeah, yeah. So definitely you want to I appreciate you for just normalizing or allowing people to have that space to have that conversation. And there's a lot of life transition that can happen though as we age. There are some patients who, are widowed and then they have new relationships. These are very important conversations that come up. So just having a game plan or having a trusted resource you can bounce these things off of and not be embarrassed about them. I feel like that's priceless.
So what's one thing you wish every woman knew before entering menopause?
Mm, that's a good one. So unfortunately, my mind always goes to the most tragic situations, and that slide that we talked about, the bleeding after menopause, kind of those
Mhm,
warning signs of what is your new normal after menopause. That
mhm,
number one thing that I would mention is trusting your body and knowing that if you restart bleeding, you have to get evaluated then. Like I said, there many times when you are bleeding after menopause, it can be something benign, or it can start off as something relatively harmless that we need to address before it turns into something that's cancerous. But I see a lot of people. I saw a patient recently, maybe it was a few months ago, and she was well into her 60s, still having her period. And I said that can't possibly be that's never normal. But she had
mm,
asked her mom, who was 80, and she had asked her other friends and they thought it might be normal, and that just broke my heart in 2026 with all the information all around. And she had an excellent primary care doctor, but she never brought it up because she thought it was normal. So I feel
mm.
that we have to kind of set a baseline. This is another life transition, just how we set our young people up when they go through puberty. These are the body changes you can experience. So we should do the same for midlife. Like this is a normal transition into your menopause journey, and this is what you can expect. But these are the warning signs of things that are abnormal, and that bleeding is number one.
And that as a primary
Mm,
care guy, we should make sure
Mhm.
that we integrate that question into,
Right.
especially to our new patients. Because usually the older patients that we've had for a while, we've come up with that conversation in the past.
Mhm.
But
Mhm.
we should intentionally if you find out they've been through menopause, one of the
Mhm.
things I do is ask that question. And then the other thing I will do is make sure they understand that if you have a postmenopausal bleeding
Mhm.
a year after, I say if you have
Yeah.
bleeding a year after, you
Right.
bring that immediately to either my attention of your
Right.
gynecologist attention. For those that
Right.
still go see gynecology on a regular basis like they should. But
Yeah, yep, exactly. And no shame associated with it, but just
right.
allowing them to know like this is what needs to be happening with my body. And the more you understand it, the more you'll be comfortable with talking to Dr. Kane about talking to me about it. Like, hey, I'm noticing this. Let's check it out. Yep. Next
Wow.
slide. So I have a few little slides in here about treatments, but I'm gonna just go in a overarching kind of big bucket theory. So the gold standard for treatment, if your symptoms are debilitating with menopause, and the most common symptom is hot flashes and night sweats, the gold standard treatment would be to replace what you lost. So as your ovaries are decreasing their hormonal production, to replace the hormones that you lost. And like I said, people experience menopause in a spectrum. People can interact with their treatments in a spectrum as well. This is not one size fits all. And obviously, hormone therapy, some supplements, some of the other medication that we use may not be right for everybody. So this is when that important relationship between the patient and their provider comes into play. Number one, you want to validate the patient's what they're experiencing. I want you to tell me everything that you're experiencing so I can tell you all of your options, and giving you all of your options, and not kind of pushing you into a corner and scaring you about your vagina closing up or all these things. Like, let's talk about where you are right now along the spectrum. It's a buffet option. We can always pick and choose things later as your symptoms get worse or get better. But I think, especially in today's culture, there's a lot of distrust. There's a lot of information on the internet. There's just a lot of information. So we got to consolidate what the patient is experiencing, what's important to them, and what options they have. So you can kind of have a team approach. Because the first time you meet me, you might not be like, oh, I think I want you to write that prescription. Let's go ahead. It might just be us conversating about what's going on. And that way, if things get worse, I have some options. We talked about what options we have. You can go to the next slide because I want to talk about some of the things not from the pharmacy that we can do. You can go to the next slide. Next slide. Just real quick. So hormone replacement therapy. So you can do implants, patches, pills, sprays, gels, vaginal treatments. There's a lot of different ways we can deliver hormones. There's a lot of different people who deliver hormones. There are physicians like me and Dr. Kane. There's also natural doctors. There's people who do pellets. There's a lot of different things. I'm going to say that wherever you get to prescribe your hormones, make sure that they are following guidelines, and make sure that they're doing it safely. So sometimes I have patients, I'm sure Dr. King has patients as well, that they may go to someone who's getting compounded hormones or hormones from online. I respect your autonomy, but also continue to have an open relationship with the other providers on your team. So everybody can know what you're taking. We can give you advice about whether we think it's safe or not. Because not we can give anybody hormones. It's like giving men steroids. If I give you steroids, you're gonna feel good. You're gonna feel buff. If I give you a lot of hormones, you probably gonna feel great. But the side effects associated or the long-term effects can be dangerous. So having a trusted relationship is the key to that.
One quick caveat and to just throw in is I want to make sure patients do discuss with their physicians because there are drug interactions that can take place. And people figure that because it's natural what they're taking,
Yes.
it may
Yes.
interact with some of those the different other medications that you may be taking for your congestive heart failure or
Right.
this. But Dr. Kane is natural. I say, well, so is strychnine, but
Yeah.
you don't take strychnine,
Yeah.
because it's natural. So.
Yes. Yes, I agree. Totally agree with that. Go to the next slide because I want to talk about these supplements yep, here we go. So other treatments. So you can do hormones. That's one form of treatment. But there's also a lot of different treatments. So when you go to somebody with your perimenopause and menopausal symptoms, you want to make sure that they're giving you the full picture. Even if, I don't want to choose that, or even if that's not safe for me, you want to make sure people are giving you all your options. So sometimes we can even use antidepressants, not just for your mood. We think they can help with your hot flashes a little bit. There's a blood pressure medicine called clonidine that we can sometimes use for menopausal treatments. And to Dr. King's point, if you got other blood pressure medicines or even other medications in general, there can be interactions with all of these things. So that's why you got to make sure you're having a trusted professional and somebody who's going to look at the whole patient before you just go prescribing things to feel better. Gabapentin, that's a medication you can use for a variety of things, but it's also been shown to help with menopause. And then these supplements. But just like Dr. King said, supplements can sometimes be just as dangerous as the medications from the pharmacy. So you got to make sure you're not having interactions with your other standard medications. You got to make sure the dosages are correct. But these are some more natural supplements that you can take, that have variable responses, because not everybody's going to respond to them. But sometimes people do want to try these things first to see if they can take the edge off or see if they can help before they have to expand to other things. So black cohosh is one of the most popular, but flaxseed, the calcium I talked about earlier, ginseng, St. John's wort, all of those are good options. And then there's two new non-hormonal medications. You guys may have seen ads, but basically they work centrally in the brain to really eliminate hot flashes. They're kind of expensive, but they are working well and they're non-hormonal. So for some of my patients who want to avoid hormones and the supplements aren't working, that's another good option that patients have access to. So the point is, there's a lot of options.
So which one will help me with thinning hair and that I won't have to keep getting weave? I'm kidding, but what any of these help with with growing my hair back? Because that's been one of
So
the big side effects for me.
Capex. Yeah. So that's a hard that's definitely a tricky one. So what we typically prescribe for that, if you're not having any other concomitant vasomotor hot flashes, night sweat symptoms where you don't need estrogen therapy as a replacement, then we just target the hair. So like Rogaine or minoxidil to help with the hair. And then you got a good beautician who will help you with styles and just the proper maintenance in between that. And then you also want to go see your primary doctor to make sure there's not another cause for the hair loss too.
I was teasing. Somebody just texted me that question.
Got it. Understandable. Next
They were
slide.
talking about your hair.
No, their hair.
So this is very important to me too, because sometimes patients just come and they want to rush in and tell me about this and get a prescription and leave. But I care about the whole person. So I want you to in during this perimenopause and menopausal transition to not forget all the normal screenings that you need. And sometimes they be too busy to see Dr. Kane, so I just got to do all the primary care and do the menopause at once. But whatever interaction you have with a medical professional, if you can volunteer that information, everybody checks your blood pressure. I think that every interaction with medicine can be an opportunity to keep you as healthy as possible. So make sure blood pressure, diabetes, cholesterol, even our infectious disease screening is very important. Just because we're older, it doesn't mean that we're not having sexual encounters and need to be screened. Our immunizations and then cancer screening, your mammograms. We recommend annually. If you want to push it to 2 years, that's reasonable, but we recommend annually, starting at age 40. And as OBGYNs, we recommend continuing it until you wouldn't want to do anything about it. So, you can stop at 70 if you're okay with not knowing if you have breast cancer and you wouldn't pursue treatment. So we have that patient centered conversation. Cervical cancer, that's your pap smears. We recommend starting at age 21 and then going to age 65 unless you have had abnormal paps or had, some kind of cervical cancer scare. And then the colorectal cancer, like we were talking about earlier, younger and younger ages. So if you're high risk, that can be based on your family history, but for all of us, at least 45 years old, we need to start that screening.
I think the thing that surprised me more recently is what you just said about stopping pap tests at age 65. I didn't know that until I'm about to tell my age, until I turned 65. And my doctor said that. I was like, what? Because I'm used to going annually, right? And
Right,
so to be
right.
told that was very surprising. But Dr. Brown, I think about then, what about cervical cancer, ovarian
Yes.
cancer? So
Yep.
I can't. I just don't want to stop having a pap test.
No.
That's just me.
Yeah, exactly. So I think the main distinct, and I got a lot of patients in their 90s that I just love seeing, and I'm never gonna stop seeing them. So the thing is, the pap test to screen for cervical cancer, you can reasonably discontinue that. But at least every 2 years, at a minimum, you need to come in to have a GYN evaluation. So the pap test, you need to uncouple that from having a pelvic exam and an evaluation. And then this is a free country. So if you want a pap test, you can request that we do a pap test. The insurance may or may not pay for it, but I feel
Mm.
like I have a lot of patients who, just for that peace of mind, they're at an age where their other friends or family may be experiencing cancers or having exposures to these things. Pap test is less than $150, so they feel like it's worth it, even if their insurance won't cover it. But I always encourage patients to continue to have an evaluation, whether you have that evaluation with your primary doctor or you want to continue with a GYN doctor. Just because they say no more PAPs doesn't mean you should stop going.
And the one thing I used to tell patients is, particularly my older clients, when I was doing health education, is you have to also think about the spread of infectious diseases, sexually transmitted infections. And so that's when you have to make sure that it, because a lot of people say, well, I can't get pregnant anymore. Why would I use,
Right.
have my partner use a condom? I say, because you're protecting yourself at that point from an
Definitely.
STI. Yeah,
Yep.
I'm sorry, I just had to mention that.
No, that's definitely very important. And sometimes, providers have their own bias, not necessarily a bad bias, but they may not suspect that someone would need screening. So that's why everyone should be screened. It should be kind of normalized to ask
Mhm.
or offer the testing as early and as often as needed. And I also want to mention the osteoporosis screening. So for patients who are low risk, you can start between 60 and 65. But if you have risk factors for bone fractures or early bone loss, you can maybe start earlier than that.
Well, Dr. Brown, it's 7:31. We don't, I mean, we could go on and on with you. But I mean, this has been wonderful. But as we close out tonight, if you can give one piece of advice to women navigating menopause, what would it be? And it might be in your wrap up here. So yeah, put the
Yes.
slide back up, Tyrone, please.
Yeah, I would just say that hopefully the things we've discussed tonight, the main takeaways are to kind of just always trust your body. Once you get that solid foundation of, you know what, I'm empowered because I understand that these changes are happening as my ovarian function is declining. I'm at risk to have these symptoms. I also know that if these symptoms debilitate me, I have options for treatment. I can speak to someone about how I can manage this mental fog, how I can manage this midlife weight gain, how I can manage these hot flashes and night sweats. It's very important to not only normalize that this is a physiologic transition, but also normalize that even though it's natural and normal, you still can get relief. And the relief doesn't have to be pigeonholed into pharmaceuticals that are hormones. There are a lot of different options that you can try to help you with that transition.
Wow. Well, this is absolutely wonderful. Thank you. Thank you so much. And um, Dr. Kane, well, let me ask Tyrone, the behind the scenes guy. I'm sorry, that's his name. Behind the scenes guy, what are your final thoughts regarding tonight's topic?
Well, first of all, I'd like to thank Dr. Brown for coming on. It was a great discussion, great conversation. I think the women learned a lot, but men who watched, I think we've gained insight as well. So I just want to say thank you. The thing I want to just bring to Mo that she said is to know your body and to seek help when things appear to be out of the normal and trust yourself. So that's the one thing that I would like to pass on to all those who listen.
Thank you, behind the scenes guy. Dr. Kane, what are your final thoughts?
Well, thank you, Dr. Brown, for coming in and enlightening us on menopause. And of course, we have you come back because there are other subject matters that you are an
Mhm.
expert in. But this was one of those topics and subjects that women have been asking me about. And I tell them quickly, I'm not the expert, not just because I'm not a woman, but because I'm not a gynecologist is one of the reasons. However, I do invite them at any point in time to ask me or my staff questions or um, have those individuals ask me their questions, I got distracted because I see Dr. Jones is asked, once you start menopausal treatment, and because I meant to ask that earlier. Once you start therapy, how do you know when to stop, or how do you determine when to stop the therapy?
And that
Good
was Dr.
questions.
Nixon. That was
Oh,
Dr.
that was
Nixon.
Nixon. I'm sorry.
Makes sense. Okay.
I'm so
So
used to
we
saying Ken, but okay.
we typically say that 5 to 7 years of therapy is a good time to maybe reassess. So we can give patients a trial away or a wean away from medication at that 5 year mark to see if they even need to continue that medication. If they are having debilitating symptoms, that's not right to take it away from them, because some people can have it even 10 years or more after postmenopause. So about that 5 to 7 years is a sweet spot to really reassess.
Unless they're high risk for something else.
Yes, exactly, exactly. Yep.
Anything else, Dr. Kane?
No. I'm looking. You saw I didn't talk much this one because I'm listening and learning. So
Exactly, exactly.
Oh,
Well, what a powerful and necessary conversation. Dr. Brown, thank you for sharing your expertise, your insight, and your commitment to helping women better understand their bodies and their health. Conversations like this truly make a difference. Tonight, we've learned that menopause is not just a phase to endure, it's a critical transition that deserves attention, respect, and informed care. We've talked about the symptoms that often go unspoken, the long term health impacts, and the importance of advocating for yourself in healthcare settings. And perhaps most importantly, we've reminded ourselves that no woman should have to go through this journey uninformed or unsupported. To everyone who joined us tonight, thank you for being part of this community. We encourage you to continue the conversation, share this episode, talk with the women in your life, and don't be afraid to ask questions and seek the care you deserve. This is how we build healthier families and stronger communities through knowledge, connection, and action. I'm Jocelyn Turner, and this has been Pause for the Truth. Until next time, take care of yourselves and each other. Good evening.
we appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.